You see a neutrophil on a biopsy. Is that acute or chronic inflammation? Easy, acute. You see a lymphocyte, chronic. But here's the question that breaks students. You see both. Which one is actually driving the disease? And why did the neutrophil show up first in the first place? Those two questions, which cell and why, are exactly how Step 1 tests this topic. So let's build the complete map. Everything starts with one idea. Inflammation is the body's attempt to eliminate the cause of injury, clear debris, and begin repair. That goal never changes. What changes is which cells do the work, how long they stay, and how much collateral damage they cause along the way. The single most important distinction, the one Step 1 tests over and over, is cell dominance. Acute inflammation is dominated by neutrophils. Chronic inflammation is dominated by mononuclear cells, macrophages, lymphocytes, and plasma cells. If you remembered nothing else but that rule, you could answer the majority of inflammation questions correctly. Let's start on the acute side. Acute inflammation is fast, vascular, and neutrophil-driven. The first thing that happens is the vascular phase. The moment tissue is injured, arterioles dilate, increasing blood flow, and venules become more permeable as endothelial junctions loosen. Plasma proteins and fluid leak into the interstitium. When that fluid is protein-rich, we call it an exudate. That exudate is what causes swelling or tumor, one of the classic cardinal signs of inflammation. Those 5 cardinal signs are worth understanding, not memorizing. Rubor, redness, comes from vasodilation. Calor, warmth, comes from increased blood flow. Tumor, swelling, comes from edema. Dolor, pain, comes from chemical mediators sensitizing nociceptors, especially bradykinin and prostaglandins. And functiolasa, loss of function, is the clinical consequence of all of the above. What drives these vascular changes are chemical mediators. Histamine is the fastest. It's released from mast cells and basophils within seconds and causes arteriolar dilation and increased venular permeability. Bradykinin comes next. It's generated from the kinin system after factor 12 is activated by exposed collagen. Bradykinin causes vasodilation, increased permeability, and pain. This is why ACE inhibitors can cause angioedema. ACE normally breaks down bradykinin, so when you block ACE, bradykinin accumulates and drives vascular leak. Then there are prostaglandins and leukotrienes, both derived from arachidonic acid. Prostaglandins are made through the COX pathway and cause vasodilation, fever, and pain sensitization. That's why NSAIDs, which inhibit COX, reduce fever and pain. Leukotrienes are made through the LOX pathway. LTB4 is a powerful neutrophil chemoattractant. LTC4, LTD4, and LTE4 cause bronchoconstriction, which matters enormously in asthma. Now the key question: why does the neutrophil arrive first? Within minutes to hours, neutrophils flood the tissue. They arrive first because they're already circulating in huge numbers. They marginate easily, and the chemotactic signals that recruit them, IL-8, C5a, and LTB4, are produced immediately by damaged tissue and activated complement. The neutrophil's job is simple and brutal: phagocytosis, degranulation, oxidative burst. It kills and then it dies. Neutrophils only survive hours to days in tissue. Once the stimulus is gone, recruitment stops, neutrophils undergo apoptosis, and macrophages move in to clean up the debris. One more acute cell to remember is the eosinophil. Think of eosinophils in 2 settings: parasitic infections and type 1 hypersensitivity reactions. Their weapon is major basic protein, which is toxic to parasites and, unfortunately, to airway epithelium in asthma. Before we switch to chronic inflammation, we need to cover a process that bridges both and is tested directly: leukocyte extravasation. This is how a neutrophil gets from the bloodstream into tissue, and it always happens in 4 steps in order. Step 1 is rolling. Injured tissue signals endothelial cells to express E-selectin and P-selectin. These bind sialo-Lewis X on the neutrophil, forming loose, transient bonds. The neutrophil rolls along the vessel wall. Step 2 is activation. While rolling, the neutrophil encounters chemokines, especially IL-8, displayed on the endothelium. These bind G-protein-coupled receptors and trigger inside-out signaling that switches integrins from low affinity to high affinity. Step 3 is firm adhesion. Activated integrins, specifically LFA1 and MAC1, bind ICAM1 on the endothelium. The neutrophil stops rolling and flattens against the vessel wall. Step 4 is transmigration, or diapedesis. The neutrophil squeezes between endothelial cells using PECAM1, also called CD31, and then follows the chemokine gradient into tissue. The disease that lives here is Leukocyte Adhesion Deficiency. Type 1 LAD is a CD18 deficiency, meaning beta-2 integrins don't work. Without integrins, there is no firm adhesion. Neutrophils roll but never stop. They never enter tissue. The result is recurrent bacterial infections, no pus formation, and the classic neonatal finding, delayed separation of the umbilical cord, because neutrophils are required to clear the cord stump. Now shift to the right side of the table, chronic inflammation. Chronic inflammation happens when the acute response fails to eliminate the stimulus or when the immune system keeps attacking normal tissue. What defines chronic inflammation is that inflammation, tissue destruction, and attempted repair are all happening at the same time. That's why it causes long-term damage. The most important cell here is the macrophage. Macrophages arrive from circulating monocytes around day 2 or 3 of an acute response and can persist for weeks to months. They are the commanders. Activated macrophages do 3 things. They release proteases and reactive oxygen species that destroy tissue. They secrete cytokines, especially IL-1, TNF-alpha, and IL-6, that drive systemic inflammation. And they present antigen to T cells, linking innate and adaptive immunity. IL-1 and NTF-alpha cause fever and upregulate adhesion molecules on endothelium. NTF-alpha also causes cachexia, the wasting seen in chronic disease and cancer. IL-6 tells the liver to make acute phase reactants like CRP and fibrinogen. Lymphocytes form the adaptive arm of chronic inflammation. CD4-positive Th1 cells secrete interferon-gamma, the single most important macrophage-activating cytokine. Interferon-gamma tells macrophages to upregulate their killing machinery and is essential for granuloma formation and maintenance. If interferon-gamma signaling fails, as in IL-12 receptor or interferon-gamma receptor deficiency, patients develop disseminated mycobacterial infections because macrophages are present but ineffective. CD8 T cells contribute by direct cytotoxic killing. Plasma cells are also part of chronic inflammation. B cells differentiate into plasma cells and produce local antibody, which is especially important in autoimmune disease. Eosinophils and mast cells can also participate. Eosinophils again point to parasites or allergic disease. Mast cells, activated by IgE, release histamine and newly synthesized prostaglandins and leukotrienes. The most important subtype of chronic inflammation is granulomatous inflammation. A granuloma is a collection of activated epithelioid macrophages, usually surrounded by lymphocytes, sometimes with central necrosis. It forms when the immune system can't eliminate the inciting agent. There are 2 types. Caseating granulomas have central caseous necrosis and are almost always infectious. Tuberculosis is the prototype. Fungal infections like histoplasma and coccidioides also cause caseating granulomas. Non-caseating granulomas lack necrosis and are usually non-infectious. Think sarcoidosis, borreliosis, Crohn's disease, and foreign bodies. Giant cells help distinguish causes. Langhans giant cells have nuclei arranged peripherally in a horseshoe pattern and are seen in TB. Foreign body giant cells have scattered nuclei. Now 4 vignette traps. First, the LAD newborn. Recurrent infections, high white count, no pus, delayed separation of the cord. That's LAD1, CD18 deficiency. No firm adhesion means no neutrophil emigration. Second, the granuloma chemokine question. A patient on anti-TNF therapy develops TB reactivation. The answer is TNF-alpha. TNF-alpha is required to maintain granulomas. Block it and granulomas fall apart, releasing mycobacteria. That's why you screen for latent TB before anti-TNF drugs. Third, aspirin-exacerbated respiratory disease. Asthma, nasal polyps, aspirin, bronchospasm. Aspirin blocks COX, shunting arachidonic acid to the LOX pathway. Leukotrienes surge and cause bronchoconstriction. This is not an allergy, it's metabolic. Treat with montelukast. Fourth, biopsy interpretation. Transmural bowel inflammation with lymphocytes, plasma cells, and non-caseating granulomas points to Crohn's disease. The cells tell you it's chronic. The granulomas and transmural pattern tell you it's Crohn's, not ulcerative colitis. Let's lock in 3 things. 1. Acute inflammation equals neutrophils. Vascular mediators first, then neutrophil recruitment. Extravasation always follows selectins, activation, integrins, PECAM1, LAD is CD18 loss. 2. Chronic inflammation equals macrophages, lymphocytes, and plasma cells. Macrophages drive disease through IL-1, TNF-alpha, and IL-6. Th1 cells activate macrophages with interferon-gamma.